Dr. Ken Landau. Thanks for watching. Let's talk about Singulair or Montelukast. This is the 23rd most commonly prescribed medicine in the United States. This year there were more than 25 million prescriptions written for the drug. It's FDA approved as of 1998, went generic in 2012. It's used for prevention and the chronic treatment of asthma in individuals over age 12. It's used to prevent exercise-induced bronchospasm, exercise-induced asthma in people over age 6. And it's used for allergic rhinitis. Allergic rhinitis, runny nose, from allergies. You could have seasonal allergies and take it if you're over age 2. That's hay fever, basically. Or perennial allergies, allergic to something in the environment that's there year-round. You can take it if you're as young as 6 months of age. Well, it also is used for off-label uses. So it's used for itchiness and urticaria or hives or wheezing from viral infections or aspirin-induced asthma. Obviously, if it's aspirin-induced asthma, stay away from aspirin. It's also used in people who are obese, who have asthma. It seems that people who are obese don't respond as well as regular weight people to inhaled corticosteroids. It seems the fat cells manufacture a hormone known as leptin, and the leptin works to increase the amount of leukotrienes that are formed, and the more leukotrienes that are floating around the system, the more likely you are to have the bronchoconstriction. And that's what Singulair does. Singulair prevents the leukotrienes from working on their receptor. Well, it's also used in elderly individuals with asthma and people who smoke cigarettes who have asthma. It's also used in children who have some wheeziness. But at least half of the kids by age 6 are going to have some wheezing oftentimes induced by viruses or emotions or a variety of other kinds of factors. And it seems that taking the Singulair intermittently really isn't all that different than taking a placebo. And by the way, it doesn't seem to work for itch, and it doesn't seem to work for atopic dermatitis or eczema either, any different than a placebo. Well, there are 3 drugs in the same family that are available in the United States. There's Montelukast, or Singulair Montelukast. It's named after Montreal, where it was discovered. There's Accolate, or Zafirlukast. That was the first one in the family that was approved by the Food and Drug Administration. And then we have Zyflo, or Xylutin. The immediate release form of that drug was taken off the market in 2008, but there still is the extended release form on the market. Well, the drug's used principally for asthma. So if we look at asthma, it's a very common condition, affects somewhere between 4 and 10% of the general population, but specifically it's more common in children, anywhere between about 10 and 20% of children, only about 1 to 3% of adults, and allergic rhinitis, or nasal allergies, well, that's prevalent in about 10 to 25 or 30% of the population. And interestingly, if you have asthma, the chance of having allergic rhinitis, nasal allergies, is probably somewhere around 80%, 80%. Asthma is a disease. It's an inflammatory disease of the airways. It causes the airways to be hyper-responsive. There's bronchoconstriction. They narrow down, they produce too much mucus, and then ultimately, if the condition goes on for too long, or if it's not treated properly, there's airway remodeling that can't be corrected. So that's why it's important to treat asthma not only when you have the symptoms, but ongoing for many individuals. The medicine, the Singulair, the Montelukast, is available in 10 milligram tablets. It also comes in 4 and 5 milligram chewable tablets, and you can get packages of oral granules, 4 milligrams also. If you take the oral granules, should be taken within 15 minutes of opening the packet. Can be taken either directly or added to a teaspoon of some cold or room temperature baby formula or breast milk. And if it's added to soft food, only could be added to either applesauce or carrots or rice or ice cream. It can be taken irrespective of mealtime. The dose of the drug once in the evening. Morning doses haven't really been studied. If an individual is over age 15, the dose is 10 milligrams. If the person's between 6 and 14 years of age, 5 milligram chewable tablet. Between 2 and 5 years of age, it's a 4 milligram chewable tablet. Or the 4 milligram oral granules would be okay, a package of that. Anywhere between 6 months and 23 months of age, the 4 milligram packet of the oral granules is the appropriate dose. Now, if you're taking it for exercise-induced bronchospasm, exercise-induced asthma, if you're already taking the singular, the montelukast, for another purpose, for asthma, and you're taking it at night, you can't take an extra dose. You only can have one dose in a 24-hour time period. And if you have a tendency to develop exercise-induced bronchospasm, you shouldn't rely on just this medicine. You should also have a short-acting beta agonist, one of those inhalers, readily available, because oftentimes the singular doesn't do what you expect it to do. And certainly it's not a treatment for acute bronchospasm. So if you suffer, in effect, an asthma attack because you're exercising, you can't use the montelukast to treat it. Well, how does the medicine work? Is it really a good medicine? Is it really an effective medicine? So in the trial, 12-week trial, average age around 30 to 35, most of the people Caucasian, slightly more women than men, people who had very mild to at most moderate asthma. These people required about 5 puffs a day of their inhaled beta agonist. They took it on a PRN basis. Well, their average FEV1, the amount of air that they could blow out in 1 second, was about 66%. That qualifies them for mild asthma. Okay, but the range was anywhere between 40% and 90%. If it's more than 80%, if you can blow out more than 80% of your air within 1 second, that's considered normal. Anything less, that's a significant issue. So these people, 66%. And when they were given the montelukast, the singular, they improved it by 13%. Minimum improvement necessary, 12%. So they were just a little bit over the line. Placebo, 4%. So if we look at the change in the amount of inhalations of their bronchodilator, their breathing inhalers, what was that? Was it significantly different? Well, remember, they started off at about 5.5 puffs regularly at least. Well, they decreased it by about 1.5 puffs if they took the singular, but decreased it still by about half a puff a day if they were taking a placebo. But if we look at the number of people who required treatment with the oral corticosteroids, prednisone, well, it wasn't any different in the people taking the singular and the people taking the placebo. And if we look at the number of office visits or emergency room visits, because the people were going to need some sort of steroid, whether it was oral or intramuscular or intravenous, there was no difference between people taking the drug and people taking the placebo. And if we look at people between the ages of 6 and 14, these people had a tiny reduction in their FEV1. They were at 72%. Remember, normal is over 80%. And they took about 3.5 puffs of their beta agonist on a regular basis. What happened when they took the 5 milligram chewable singular? Well, their FEV1 increased by only about 9%. But if you took a placebo, it increased by about 4%. Now, statistically, that's different. On a clinical basis, remember, you got to get to 12% to show that the airway is a reversible issue. They didn't get there. And if we look at the decrease in the puffs, remember they start off at about 3.5 puffs of their inhaler a day. Well, in the group taking the singular, the montelukast, they only reduced it by about half a puff a day, by a quarter of a puff if they took placebo. So if we look at the inhaled corticosteroid dose, if we look at another group, average age, say about 40, 92% Caucasian, these were stable asthmatics. They had an FEV1 of 84%, so they were in the normal group, but they were controlled by the inhaled corticosteroids. So what happened on these individuals was they were stabilized, and then they had their dose of corticosteroids reduced to the lowest level, actually reduced it by about 37%. That's in people, just normal people with asthma, without giving any other kind of medicine. They were just taking too much of the too much of the inhaled steroids. So reduced it. Now, once they started the singular, they could still reduce that by about 45 to 50%, as opposed to about 30% if they were taking placebo. So what that really means is that people who are out there in the general society are not being well managed, at least a significant number of them. And if you're already taking a low dose of an inhaled corticosteroid, say the beclomethasone, you take a low dose, well, if you're not well controlled, then adding Singulair might be a little bit better than adding a placebo. But there's no added benefit if you take more than 10 milligrams a day. Good news is that the effectiveness is maintained over 24 hours and there's no rebound when you discontinue it. If we look at exercise-induced bronchospasm, you should take it about 2 hours before you exercise. You're not protected necessarily if you take it 8 hours or if you take it 24 hours before you exercise. And if you do take it, the fall in the FEV1 in adults, people over age 15, well, if you take it 2 hours before you exercise, you're still going to decrease the FEV1 by about 13% with the Singulair, 22% with the placebo. And if we look at children instead of adults, again, the difference is even narrower. So it doesn't seem to be all that effective. Well, how about allergic rhinitis? Allergic rhinitis, people complain of symptoms of either nasal congestion or runny nose, or they have some nasal itchiness, or maybe some sneezing. Well, if we look at a score and the reduction, if you have seasonal allergic rhinitis, the reduction from baseline is a tiny amount if you take placebo, a smidgen more if you take the Singulair, and much better if you happen to take loratadine, one of the antihistamines. Now, if you have perennial allergic rhinitis, you have positive skin test, you're allergic to either the dust mites or animal dander or mold spores. Again, loratadine, which is commonly used over-the-counter antihistamine, seems to be better than Singulair, and Singulair is only slightly better than taking placebo. Well, the standard side effects, you can't really tell the difference between the placebo and the Singulair, or the Montelukast. It doesn't really have a whole lot of typical side effects. So it has a little smidgen of fever, or headache, or pharyngitis, or cough, or diarrhea, but really not different than placebo. Well, the drug should not be used for acute asthma attacks. You should always have the appropriate rescue medicine right at hand, the inhaled corticosteroids. If you start taking the Singulair, could perhaps be gradually reduced, but you shouldn't abruptly stop taking your inhaled corticosteroid if you happen to start on the Singulair. And if you happen to have aspirin-induced asthma, well, stay away from the aspirin. That's obviously much more important. Now, one of the side effects that's very uncommon is you could have something known as the Churg-Strauss syndrome. That's where you have the asthma, the eosinophils in the bloodstream, and then you could have some inflammation of the blood vessels themselves. That's a very important condition. Fortunately, it's very rare. Also, if you happen to take the chewable tablets, they contain some phenylalanine, so that's important if you happen to have phenylketonuria. But the most important thing, probably, are the neuropsychiatric events that have been reported by taking the medicine. So the FDA approved the medicine, approved Singulair, in 1998. Didn't get around to adding extra caution until February of 2019. It was discovered in the post-marketing studies that the drug sometimes associated with agitation and aggressive behavior and hostility and anxiousness and depression and sometimes disorientation and disturbances in attention and abnormal dreams or nightmares or even hallucinations or insomnia or irritability and sometimes in memory impairment and tics and tremors and even suicidal thoughts. Well, obviously, those are all very significant for a medicine that has kind of marginal effects. So if a person's taking the medicine, certainly should be monitored for any changes that might suggest the person is becoming suicidal. Well, in 2007, so remember, 1998 it was approved. In 2007, Merck's the drug company that makes the drug, they added several neuropsychiatric events to the post-marketing information on the label. But they wanted to combine it with the loratadine, because the loratadine seems to be even better than the Singulair. They wanted to combine it into a single pill, have the loratadine and the Singulair. The FDA said, oh, you got to be kidding. No, we're not going to allow that. Then the FDA convened an advisory committee. And the reason they did it is because there was concern about the main indication for use of singular montelukast in very young children. The meeting was held because the parents of the children formed a group. They called it the Parents for United Pharmaceutical Safety and Accountability. And that, together with another group called the Montelukast Side Effects Support and Discussion Group, they wrote a letter to the FDA in about 2008. And they said, hey, we got an issue with this medicine. It's used for cough, but we think that it might have too many side effects. And actually, it's an important condition because about 2.5 million kids less than age 16 are taking the medicine, mostly between ages 6 and 11, some of them between ages 12 and 16, fewer between ages 2 and 5. The most common indication in children is asthma. Second most common indication is allergic rhinitis, a runny nose, maybe some vasomotor rhinitis. Well, a member of the committee, that FDA advisory committee, suggested that probably they ought to just not allow the drug for allergic rhinitis because it doesn't seem to work very well. And also, they said, you know, I've been prescribing, the member of the committee said, I've been prescribing this for asthma, and I stopped writing prescriptions because it didn't seem to work very well for that condition either. Well, it wasn't until March 4th of 2020 when the FDA strengthened the existing warnings about serious behavioral problems and the mood-related changes associated with montelukast, caused them to put a black box warning, or a box warning rather, on the label, the package insert of the medicine, and doctors are now supposed to inquire about any history of psychiatric illness prior to prescribing the medicine and advise all patients or their parents that if there are some kind of peculiar neuropsychiatric behaviors, that they ought to stop the medicine instantly and contact a healthcare worker. Well, that's for a drug, as I say, where it really isn't an exceptional medicine. It doesn't really seem to work all that well. Interactions, fortunately, none. Doesn't interact with birth control pills or blood thinners or thyroid medicine or sedatives or hypnotics or even the benzodiazepines. No change in drug inducers or drug inhibitors, the enzymes that change the drugs, other kinds of drugs, so no interaction with that. Pregnancy, it doesn't seem to be a problem. Animals have been treated with 100 times the human dose, still no kind of problems. We know that poorly controlled asthma in pregnancy might be a problem, increase the risk of preeclampsia, increase the prematurity, deliveries. Seems to be associated with low birth weight children, small for gestational age children. So asthma needs appropriate treatment, but whether it's singular or not, that's a different kind of issue. Lactation, again, no effect that we know of. Don't know that it alters the milk production in pediatric age group. Certainly it seems safe for most children with asthma between the ages of 6 and 14, but it's not established for children who are younger than that. Seems to be okay for seasonal allergic rhinitis or perennial allergic rhinitis, at least as far as the major side effects, but not as far as those behavioral, neurocognitive side effects that I mentioned. Doesn't seem to alter the rate of growth of children. Geriatric population might have a slightly prolonged half-life in the bloodstream, but that's really the only thing. No adjustments necessary for people who have either mild renal or liver impairment. Doesn't seem to be mutagenic or tumorogenic, doesn't cause any kind of tumors, doesn't change fertility. Overdose is really not an issue with this, even at 900 milligrams a day. Remember, the normal dose is 10 milligrams a day. So you take the whole bottle and maybe develop some abdominal pain or sleepiness or thirst, or some people develop headache or vomiting or hyperactivity. The way the drug works is it works on chemicals known as leukotrienes. Leukotrienes come from basically arachidonic acid. Arachidonic acid, if it goes on one pathway, that's what aspirin blocks. If it goes down the other pathway, the leukotriene pathway, that's what Singulair blocks. What's released from a variety of cells, including the mast cells and the eosinophils, they bind to receptors in the airway. And when they do that, these receptors are present in the smooth muscle cells, and on the macrophages, the type of a blood cell that's in the lung, and also other pro-inflammatory cells like the eosinophils. And when that happens, when you bind the leukotriene to those receptors that happen to be on very important structures, then we get some swelling of the airway, some edema of the airway, we get smooth muscle contraction, and that leads to the bronchoconstriction. That alters the cell activity associated with the inflammatory process, and basically the same sort of thing happens inside the nose. It seems that, in theory at least, Singulair, or Montelukast, can block the production of excess mucus, block the inflammation, block the bronchoconstriction, and block the smooth muscles so they can't constrict, so they relax instead. Well, the drug is orally active, of course, binds with high affinity to these receptors, and it seems that there's some evidence that women respond a little bit better than men. When you take the medicine, rapidly absorbed, the time to the peak concentration inside the bloodstream, it's about 3 to 4 hours with the tablets. If you take the chewable tablets, it's only about 2 to 2.5 hours. Bioavailability is about 65% of the medicine. It's not changed if you take it with meals, but if you do take it with a fatty meal, it could decrease the peak serum concentration by about 35%, and it increases the time to the maximum concentration, but it doesn't seem to do anything to the total amount in the system. If we talk about children between the ages of 6 and 11, they have about a 60% increase in their area under the curve, the amount that's in the system, compared to adults. If we look at younger children, maybe about a 90% increase. About 90% of the medicine, 99% of the medicine seems to float around bound to plasma proteins. It's extensively metabolized. Actually, when we evaluate the plasma, we can't find any of it in adults or in children. The half-life of the medicine, somewhere between about 2.5 and 5.5 hours. About 85% is going to go out in the feces, less than 1% going out in the urine. Now, here's the issue. This is a medicine for asthma. So the international guidelines, we call them GINA, G-I-N-A. Where does Singulair, or Montelukast, or members of the family fall in? Well, it doesn't. The preferred treatment for asthma is inhaled corticosteroids. And if inhaled corticosteroids don't work, then we use the long-acting bronchodilators. And sometimes we have to use the short-acting bronchodilators if a person has an acute attack. And if a person has really bad asthma, then we could use some of the Spiriva in addition to the inhaled corticosteroids and the long-acting bronchodilators. And sometimes we even have to use some of those biologics. But if we're talking specifically about Singulair or Montelukast, according to the guidelines, it's not a preferred treatment. It could be used in stage 2 or stage 3 asthma if everything else doesn't work or if there's some reason you can't take anything else. And how does it do in allergic rhinitis? Well, the official guidelines from the American Academy of Allergy, Asthma and Immunology, they say, go take an inhaled corticosteroid, much more effective. And if the inhaled corticosteroid doesn't give you all the relief you want, take an inhaled antihistamine as well. Or some people can take an oral antihistamine, and then only if everything else doesn't work, then maybe you could consider using Singulair. Well, the sales were going along gangbusters until 2012 when it went generic. As soon as it went generic, sales off 90%. It had been Merck's bestseller. It was their #1 drug. In 2011, global sales of this medicine, it really doesn't do all that much, was about $5.5 billion. Domestically, it was about $3.5 billion. Well, actually, in 2014, Merck wanted to bring the medicine over the counter. Food and Drug Administration panel looked at the evidence and voted 11-4 against allowing them to bring the drug over the counter. Well, how much does it cost? Well, for a month worth of the 10 milligram tablets, if you go over to Costco, it's going to cost you $18 cash. If you go over to Walgreens, the same amount of the drug that you could get for $18 rather, over at Costco, costs you $162 over at Walgreens. If you have a coupon like you could get from GoodRx, The price is anywhere between about $10 and $40. The $40, the high price, that was at Walgreens too. And if you want the brand name, the single R itself, the price is anywhere between about $260 and $300, the highest price again at Walgreens. And if you have a coupon from GoodRx, anywhere between $230 and $250, again the highest price over at the Walgreens. So there's single R or Montelukast. It's among the top 25 drugs that are prescribed here in the United States. But it's not very helpful for the most part in either asthma or nasal allergies. While it can help some people a little bit, it's really not first-line medicine according to any of the international guidelines for either asthma or hay fever. Now, I'm not sure why the drug is still so popular, because we have a lot better medicines on the market. After more than 20 years on the market, remember, the Food and Drug Administration finally decided just in March of 2020 that they had to add extra warning because of a lot of neuropsychiatric problems that were associated with taking the drug. So word to the wise ought to be sufficient. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified when we post new videos. I appreciate your interest. I'm Dr. Ken Landau.